So this is something that also came up as a question earlier. Do some patients respond differently to medications? And we do know that there are differences in terms of how people respond to the medications. So African Americans and Asian Americans can experience side effects at lower dosages than Caucasian patients, largely due to the way that they metabolize the medication. So there's a system called the cytochrome P450 system. Basically, most of our medications get metabolized in our liver. It gets broken down there. And so everybody's system is a little bit different, and these are things that developed over time. So genetically, we know that there are differences. So people may respond slightly differently depending on their background. I think that the main thing is that, for patients who are experiencing those sort of symptoms or coming from these groups, you probably want to start the antidepressants at a lower dose and titrate slower. But you still want to make sure you're titrating up. We don't want to keep patients at low, ineffective doses. That's the one thing that we want to avoid. So this is something that we referred to earlier. There was a trial that came out recently called STAR-D, which was sort of sequential treatment for depression, and they wanted to see what happens when we start patients on medications. And then, we all know that not everybody, the first antidepressant that is used is not always going to be the right antidepressant for individuals. So how should we go through, treating patients was the goal of this study. And so we know that in terms of people getting better, we know at the first step, a little bit more than half of the people, get better. Or a little bit more than a third get better, not half. So 36.8%, right? And then, so at some point, with that first step, that suggests that 2/3 of the patients aren't necessarily going to get better with that first trial of medications. So at some point, you need to consider additional steps. So each of these steps tells you that some people continue to get better, but again, there are people who don't respond even as we're switching medications. So it's not as though we can say that a patient is always going to get better by using medications. And we do need to go through multiple trials sometimes for some patients to try to find what's going to work best for them. But again, you can see that this remission rate continues to decline at every step because these patients are just more resistant to treatment than those people who responded earlier. And so we also know that those people who needed to get down to these different stages in terms of treatment also had higher relapse rates as well. So again, we know that there are people who are just not going to respond as well to these medications. And these were not just people that were on those SSRI medications that we talked about, but they actually went through and used some of these other antidepressants. And they, for some of these patients, they used augmentation strategies where they were on multiple antidepressants at the same time. For some patients, they were allowed to use psychotherapy. So again, we know that not everybody gets better. Again, recovery is the rule. Most patients will eventually get better. And even those patients who don't get treatment, at some point, they might get better too, although they're, again, more likely to go back into relapse and have depression again if they're not treated. So the thing is that we can get them better, and we can get them better sooner than if we just left them alone. But there are going to be some patients who don't improve. So I guess I can go through this if you'd like. So in terms of sort of good decision points in terms of treatment. So let's see. So I think so this is just sort of an example of what might go on with a patient. So if in the first couple of weeks, patient, if we took their PHQ, if we did the PHQ-9 with them, they're scoring an 18 at this point in time. And the patient, and let's say the client comes back to your office and says, I didn't go see the doctor, but I stopped the medication. I just felt like it wasn't working for me at this point. So, here, there are problems that might, if you ask the patient why, they might give you a couple of different reasons why they stopped the medication. They might just tell you, I just couldn't take it for whatever reason, or they might say that I'm feeling a little discouraged. I'm not getting better immediately. I was expecting that as soon as I took this medication, everything would be better. Or they might say, I'm experiencing some side effects. I'm having some stomach problems as I'm taking these medications. I think that the main thing here is that, if you were going to work with a patient, you probably want to acknowledge their side effects, as we mentioned, if that was the problem. Acknowledge that they're occurring, but let them know what we often see with these sort of medications, that these side effects will get better over time, and that we'll start seeing that effect in terms of them getting better with medications also over time as well. So if they stay on the medication, if they're able to be patient with it, we're likely to see a better response. Another thing would be changing the dose. If it turns out that the side effects are really a real serious problem, maybe we just need to change it. If we started, let's say, at a higher dose, let's say we were starting at 20 milligrams of fluoxetine or Prozac, cut it back to 10, or suggest to the patient that maybe they should ask their doctor about this. And again, I think that the main thing is communication between everybody who's working with the patient, because sometimes when I'll be in the office and I'll see somebody come in, and all of a sudden, as I ask them about their medications, I find out, oh, you stopped the medication, or oh, you're taking more, and so I think that the main thing is letting everybody know, because it's a team effort, and I think that the more everybody knows, we're going to be able to work with the patients best. And then patient education as well, letting them know what to expect from the medications. Again, adherence problems, as we mentioned, should they take it in the morning, at the night? I think the main thing is what works best for the patient. Sometimes, so let's say, after the 4th week, the patient's on, let's say, fluoxetine 20 milligrams, as we mentioned before. PHQ-9 is still 16, when we rechecked it. Basically, hasn't been much of a response. And so at this point, it would just make sense to go ahead and just start increasing the dose. If we're not really seeing much of a response, we would expect sort of around by week 6 or so that people are really getting better, and this is not really much of a change. As we talked about earlier, the PHQ-9 can fluctuate. So, really moving from 18 to 16 is not that big of a change, and so it would be reasonable to change the dose and increase it up. As we mentioned earlier, for using a medication like fluoxetine, that therapeutic range is going to be somewhere between, let's say, 10 to 60. So there's certainly room to increase the medication and still do okay. So let's say the doctor was notified and the dose was increased to 40 milligrams. Patient's PHQ score is still 15. Basically, we're not seeing much of a response. It's been 8 weeks now. It's been 2 months on this medication. This is a pretty reasonable dose. I mean, we could still try increasing the dose up to 60 milligrams, but at some point, you've got to say, is this really working for us or is it not? And it would certainly be reasonable at this point to say, well, this doesn't seem like it's been working for you. Let's try a different antidepressant.